Hello friends. So we are starting this new course, Ultrasound CBT course, new series actually, by which you can learn all these chapters and topics very easily in a short period of time. So just subscribe this YouTube channel. I am starting today's session, that is ectopic pregnancy. This is the first topic. Gradually, we will cover many topics. So, ectopic pregnancy is defined as pregnancy implanted outside of the endometrial cavity. So, ectopic pregnancy remains the one of the leading cause of death, of maternal death, and account for 1.4% of all pregnancy and 15% of the maternal death. Although the incidence of ectopic pregnancy is increasing, the mortality has been declining. It's less than less than 1 in 1000 cases. If we compared it earlier, it was around 3.5 to 1000 in 1000. So it gradually declining because increased incidence is due to increased prevalence of the risk factors, and decrease in the mortality is due to earlier diagnosis in nowadays, increase awareness, and improve diagnostic capabilities of the ultrasound machine. Classical clinical triad of the ectopic pregnancy is abnormal vaginal bleeding, pain, and palpable adnexal mass. Other presenting signs and symptoms may be amenorrhea, adnexal tenderness, and cervical motion tenderness. Risk factor of the ectopic pregnancy are various. Because of that, increasing prevalence of the ectopic pregnancies nowadays. So tubal abnormality which prevent or delay the passage of the zygote, previous ectopic pregnancy, histiotubal reconstructive surgery, PID like chlamydia, salpingitis and gonorrhea, IUCD, increased maternal age, increased parity, previous cesarean section, infertility, endometriosis, ovulation induction drugs, IVF and embryo transfer. So because of these, there is increased chances of ectopic pregnancy. What is the DD? So DD is ruptured hemorrhagic cyst, early pregnancy failure, TO degenerating fibroids, ovarian cyst, PID, DUB, spontaneous abortion, and endometriosis. These are DD of the ectopic pregnancy. What are the different locations of the ectopic pregnancy? So ampullary or ischemic portion of the fallopian tube is the most common location. About 95% are located at this location, that is ampullary portion. Second most common site is interstitial pregnancy, around 2 to 3% of all ectopics. Other are rare, that is ovarian, cervical, and abdominal site. So these are the different sites. It may be cervical, it may be intramural also, interstitial, or most common is the tubal ampullary portion of the tube. It may be ovarian also and cervical also, which are rare. It may be abdominal and it may be heterotopic also, where the intrauterine as well as ectopic is present simultaneously. What are the USG feature of the ectopic pregnancy? So you remember TB is the mainstay of the imaging. What are the features? The extrauterine gestational sac. Sac may or may not contain yolk sac or embryo. There may be adnexal ring sign, large free fluid in pelvic and Morrison's pouch, complex free fluid in the pouch of Douglas and abdomen, which represent the hemoperitoneum, pseudogestational sac, poor decidual sign, endometrium may contain blood, absent double decidual sign. These are the USG feature of the ectopic pregnancy. There are some important signs in the ectopic pregnancy which helps us to detect ectopic pregnancy. So adnexal ring sign, that is presence of ring-like structure near ipsilateral ovary due to the growth of sac in the fallopian tube. So because of that, because of the decidual reaction and the clotted blood and surrounding it and hematoma, it look like a ring-like structure because it's surrounded by the sac is surrounded by the fallopian tube where there is a hematoma is forming. So this is a case of live tubal ectopic pregnancy, and the fetal cardiac activity is also present in this situation. The uterus is separate and having no internal sac in it. Other sign is ring of fire sign. There is ring of increased flow on color Doppler around the gestational sac of the ectopic pregnancy on color Doppler. So this is a color sac, ectopic sac, where there is a color flow is there around the sac. There is a bagel sign. It is a type of bagel is a type of braid with central hole. So sonographically, centrally hypoechoic hole of the bagel represent the gestational sac, and thick surrounding echogenic dough of the bagel represent the trophoblastic tissue. So this is the bagel braid, and it look like bagel. So this is the bagel sign where the echogenic decidual reaction and hematoma, and centrally anechoic area, that is the gestational sac. Then next is blob sign. Blob is there is a finding a extrauterine inhomogeneous adnexal mass. So this is the blob sign where a nodule or blob-like structure which is near the ovary. This is the ovary and this is the blob. Blob is like a wound, foda. Now, sliding sign. When pressure is applied over the extrauterine mass by TVS, this mass moves away from the adjacent ovary because the ectopic pregnancy is usually extrauterine in location. So this sliding is positive, then the chances of ectopic pregnancies are more. It indicates that this sac or extra mass in question is not attached to the ovary. So this is the video showing sliding sign. This is the ectopic sac, and this is the ovary, and this is moving away from the uh, ovary. You can see, have a close watch, and this is again a bagel sign is seen here, where the thick echogenic ring with central anechoic area. Now, how to differentiate between the corpus luteal cyst and the ectopic pregnancy? So, corpus luteal cyst is eccentrically located within a rim of ovarian tissue because it present in the ovary. The tubal sac is concentric ring, often within a hematoma that may confine to the fallopian tube or may extend outside it. Tubal ring is more echogenic than the ovarian parenchyma, whereas the corpus luteum is less echogenic than the ovarian parenchyma. Next differentiate point is the wall of the corpus luteum is usually less echogenic than the endometrium, and tubal ring of ectopic pregnancy is more echogenic. So rule of thumb is the ectopic pregnancy tubal rim is more echogenic than that of the endometrium, and than that of the ovarian parenchyma. This is the coronal transvaginal scan, shows the empty endometrial cavity. This is the empty endometrial cavity, and there is a gestational sac and the embryo on this side. Decidual cast or pseudogestational sac of ectopic pregnancy is important finding, where the decidual cast of or pseudogestational sac of the ectopic pregnancy is present is it is a intrauterine fluid collection which is surrounded by the single decidual reaction. It is as opposed to two concentric ring of the double decidual sign. So in pseudosac, which is just a collection of the fluid or blood in the endometrial cavity, it is not having double decidual sign because there is no true sac is present. So this is the pseudosac where the collection of the fluid is there and it is surrounded by the single decidual sac decidual reaction. Here again there is a collection of the fluid which is having the tapering end toward the cervix because it's a fluid collection in the endometrial cavity. How to differentiate with the true sac? So in pseudosac, absent double decidual sign and point tapering end, that is acute angle toward the cervix. On color Doppler, there is absent peritrophoblastic flow is there. On also there is yolk sac and fetal pole are absent and it's having the central position. So this is having the central position, tapering end toward the cervix. There is no double decidual sign, only single decidual reaction is there. The rim is there, and there is a single no yolk sac or fetal pole is present in this pseudogestational sac. Whereas the true intrauterine sac having eccentric position, not the central one, there will be presence of fetal pole and yolk sac, and there is double decidual sign will be present. Also, peritropoblastic reaction will be there in the true sac. Now, next is interstitial ectopic pregnancy. The thing we have discussed till now is the about the tubal pregnancy. There is another entity, interstitial ectopic pregnancy, which is the rupture later than the other tubal gestation because it is surrounded by the muscle of the uterus. So mortality of the interstitial pregnancy is twice that of other pregnancy, tubal ectopic pregnancy, because it is surrounded by the highly vascular area. So bleeding is more in this ectopic pregnancy. Now, what are the USG feature? There will be myometrial thinning of the less than 5 millimeter. Sac is eccentrically placed, that is, and it present high lateral in the cornu. There is no double decidual sign because it's outside of the endometrial cavity, and there is an important sign is there, interstitial line sign. Interstitial line is a thin echogenic line extending from the endometrial canal up to the center of the interstitial sac or hemorrhagic mass, and it is seen in 92% of the interstitial ectopic pregnancy. Actually, this line is the non-distended empty endometrial canal. So, what are the features? So, what are the features? Empty endometrial cavity, interstitial line sign, myometrial mental sign, that is gestational sac is surrounded by the myometrium which is very thin. Then bulging sign, the gestational sac in the uterine fundus resulting in the abnormal bulging of the uterine contour. So this is the interest area of the interstitium area is having the, you can see this very highly vascular area, and this is the present in the corn, one side of the uterus. So this is the a case of interstitial ectopic pregnancy where the sac is present, ectopic sac is present in the interstitial region, and the endometrial cavity is stopped here, and there is a thin line is there which joining is to the this sac or complex mass. This is again an interstitial ectopic pregnancy, and the endometrial cavity is not attached to it in any way. Again, there is thin myometrium surrounding it. This is known as myometrial mantle sign. Very thin endometrium is there around the sac, which is less than around 5 millimeter, less than 5 millimeter. So this is a case of ectopic pregnancy or coronal ectopic pregnancy. You can watch, have a watch. This is the endometrial cavity, and this is the endometrial cavity, and this is the sac. Here is the sac, which is present, which is not attached to the in the endometrial cavity and far from the endometrial cavity. This is the ectopic pregnancy. There is thinning of the myometrial mantle of 3 millimeter, that is less than 5 millimeter. Cervical scar implantation. This is the another entity. Uh, it appeared to be increasing in trend because of the increasing prevalence of the cesarean section. Clinical feature will be painless vaginal bleeding and history of one or more cesarean section. USG feature is that sac implanted in the lower uterine segment. There is local thinning of the myometrium and usually prominent vascularity at the implantation site is there. So, what are the USG feature of scar pregnancy? Empty uterine cavity, clearly visible empty cervical canal with no contact with the gestational sac, no adnexal mass or free fluid in the pouch of Douglas is there. There is gestational sac in the anterior inferior uterine wall, best seen on the sagittal image. Myometrial thinning anterior to the gestational sac will be there, and gestational sac with echogenic margin and peritropoblastic flow on the scar site will be there. So this is a case of uh, scar ectopic. This is the location of scar ectopic where there is thinning of the myometrium anterior to it. This is the anterior bladder is present, and posterior the uterus is present. And this is present at the level of cesarean scar. So this is again a sagittal section of a uterus and showing a complex mass is there, sac-like structure is there with thinning of the myometrium anterior to it. And it is quite distance from the cervical canal. Cervical canal is empty. And there is a peritropoblastic flow is there. This is again scar implantation, cervical scar implantation. Again, this is the sac and protruding into the urinary bladder. Flow is there. But how can we differentiate between the cervical scar implantation and spontaneous abortion? So vascularity is in incomplete important distinction factor between the cervical implantation and incomplete abortion. So in cervical scar, there is a vascularity is present. In incomplete abortion, it is absent. And crampy pain is present in the abortion, but not in the cervical scar implantation. Management is DNC is not done because the thin lower uterine segment may perforate. Medical therapy is more common with methotrexate taken systematically or often injected locally as well. Presence of live fetus is there if then there is injection of the potassium chloride to be done and into the embryo to stop the cardiac activity. Catastrophic hemorrhage may result with the need for complete cystectomy and the if involved major bladder reconstruction may be done in case it rupture is there. Now next is cervical pregnancy. It is rare. Vascularity is important distinction feature between the cervical implantation and a incomplete abortion. So in cervical implantation again the vascularity is present. In incomplete abortion it's absent and treatment is typically with the injection of a ACL. So this is the location of the cervical pregnancy, that is it is into the cervix, cervical wall, not in the canal. It is away from the cervical canal. This is the case of uh, cervical ectopic pregnancy, and the cervical canal is separate. It is separate from the cervical ectopic pregnancy. This is again a case of cervical ectopic pregnancy, and the cervical canal is passing from behind it. This is again cervical. Uh, this is again cervical pregnancy, ectopic pregnancy with live fetus. Here, the in abortion program, gestational sac will be present in the cervical canal, and there is crampy pain will be there. This is abortion pregnancy, abortion progress, where the product are inside the cervical canal. So what are the difference between cervical ectopic and abortion? In cervical ectopic, implantation of gestational sac in the cervix, and gestational sac is not attached in cervix in case of the abortion. In abortion, in cervical ectopic, it is round gestational sac is there, and in abortion, there is sac is irregular with deformed borders. In cervical ectopic pregnancy, ecogenic surrounding margin is there. There is no ecogenic ring in the case of abortion. Peritrophoblastic flow, as already mentioned, is present in the cervical ectopic but not in the abortion. It is well-defined a yolk sac or fetal pole in the cervical ectopic, where there is poor visualization of the fetal part is there, which is usually dead. No blood product in the endometrium will be there, while blood product will be in the endometrium will be present in case of the abortion. In cervical, hourglass or figure 8 shape with gestational sac of more than 1 week will be there. There is in case of abortion, globular enlarged uterus is there. Closed internal cervical os in case of the cervical ectopic pregnancy, whereas it's open in case of the abortion in progress. Fetal cardiac activity below the internal cervical os is the most specific finding in case of the cervical ectopic pregnancy, whereas absent fetal cardiac activity below the internal cervical os in case of the abortion in progress. There is negative sliding sign in case of the cervical ectopic pregnancy, whereas positive sliding sign in the abortion in progress. Next is ovarian ectopic pregnancy. It results when the fertilized ovum is fertilized in the retained in the ovary. So ovarian pregnancy composed of the around 3% of the ectopic pregnancy. If the adnexal mass is documented, gentle bimanual US examination should be performed to evaluate movement of the identified mass. If the mass moves separately from the ovary, it likely to be tubal ectopic pregnancy. If the mass moves with the ovary, and it is more likely to be corpus luteal cyst or a ovarian ectopic pregnancy. So at USG, ovarian ectopic pregnancy demonstrated thick surrounding ring. An ecogenic ball is another distribution sign. With an ovarian ectopic pregnancy demonstrated a more ecogenic wall than the corpus luteal cyst. So what are the USG feature? There is empty endometrial cavity. There is gestational sac with thin circumferential echogenic margin in the ovary. Gestational sac inseparable from the adjacent ovarian parenchyma. Peritrophoblastic fluid surrounding the gestational sac will be present. Yolk sac and fetal pole with or without cardiac motion can be present depending on the gestational age. This is a case of ectopic pregnancy. In the ovary, the ovarian follicles are there surrounding it, and there is a thick echogenic rim is there with central anechoic area in case of the ovarian ectopic. Uh, Flow, peritrophoblastic flow will be present around the ectopic. Next is it important, interesting ectopic pregnancy, that is intramural ectopic pregnancy. If an intramural ectopic pregnancy, the gestational sac is located in the uterine wall and completely surrounding by the myometrium and separate from the endometrial cavity and the fallopian tube. That is, the sac is burrowed into the myometrium. Intramural pregnancy is extremely rare. It accounts for the fewer than 1% of the total number. Clinical symptoms are non-specific, include abdominal pain, vaginal bleeding, and positive pressure pregnancy test. USG feature are a gestational sac in the uterine wall that is completely surrounded by the myometrium without visualization of the gestational sac in the endometrium or fallopian tube. Peritrophoblastic flow is usually present at color Doppler. 3D ultrasound and MR image can help to localize the gestational sac. Factors that predispose to development of intramural pregnancy include adenomyosis, in vitro fertilization, defective trophoblastic activity, previous uterine trauma like DNC or myomectomy. Next is abdominal pregnancy, which is very rare, often result from uterine rupture from an interstitial ectopic pregnancy. Maybe rarely occur from direct implantation. When diagnosed in the first trimester, these pregnancies are typically treated in similar way to tubal ectopic pregnancy. When diagnosed in the third trimester, abdominal pregnancy may result in viable neonate. So you have to remove the fetus by the operation. Then ultrasound feature, it empty uterine cavity, lack of normal hypoechoic rim of the myometrium surrounding the gestational sac, most often sac located in the pouch of Douglas. Various abdominal placental implantation site may be multiple, omentum, mesentery, bowel, liver, spleen. Echogenic free fluid, that is hemorrhage, may be present. So this is the case of abdominal pregnancy. This is the endometrium cavity, uterus is empty, and there is a fluid which is not present in the fallopian tube but in the abdominal cavity. So this is again, this is the uterus which with having the empty endometrium, and there is fetus is present which is quite large and present in the adnexa, which is in the actually abdominal cavity. This is the video of the abdominal pregnancy. This is the sac in the abdomen. This is the sac in the abdomen. Fluid is there. Free fluid is there. Sac. And there is, and this is the uterus which is having no sac inside it. Pregnancy of unknown location or PUL. This term refer to an empty endometrial cavity with no evidence of intrauterine gestational sac or RPOC and no extrauterine pregnancy visualized. Heterotopic pregnancy, or heterotopic gestation is a coexistence of the intrauterine as well as ectopic pregnancy. It should be suspected in patient undergoing ovulatory induction drugs or IVF. Incidence in general population of heterotopic pregnancy is 1 is to 7,000, and incidence of heterotopic pregnancy in the IVF patient is 100%, 1 into 100 or 1%. This is the case of ectopic pregnancy where the intrauterine sac as well as ectopic location is present. Management of ectopic pregnancy. Conventional management of ectopic pregnancy is surgical with resection of the deceased tube. Laparoscopy is often used for definitive diagnosis and for the conservative surgical procedure like salpingotomy. Medical management can be done by cell growth inhibitors like methotrexate, which are injected systematically, they either IV, IM, or oral administration. Methotrexate kills the rapidly developing trophoblastic cell, which then reabsorb. Methotrexate therapy, medical treatment with the medical therapy is now widely used and acceptable to the patient also. It should be given only when the diagnosis of ectopic pregnancy has been firmly established. What are the contraindications to medical management or medical methotrexate therapy? So evidence of the tubal rupture such as hemiperitoneum is contraindication. If the patient is non-compliant, if size of the gestational sac more than 4 centimeter in the maximum diameter, presence of cardiac activity, SCG level more than 5,000 milli-international unit per ml, uh, then you should not try this methotrexate therapy. Now some multiple choice questions for the ectopic pregnancy. A 30-year-old female present for the obstetrical sonography at 7-week gestation with left lower quadrant pain and spotting. Her SCG level has risen to a subnormal rate over the last 48 hours and no intrauterine sac is identified sonographically. Which of the following is the most likely explain the symptom and sonographic finding? So answer of this is ectopic pregnancy because it's having the left lower quadrant pain and smarting and C level was rising subnormally and no intrauterine gestational sac is identified. A 19-year-old woman, Gravida 2 Para 1, present to the emergency department at 11-week gestational with vaginal bleeding. Laboratory tests show beta SCG of the 2 lakh 19 international unit. Sonogram is ordered to confirm which of the following. So what is the answer? So here the answer is molar pregnancy because the level of the SCG level is quite high. So this high level is associated with the molar pregnancy, not the ectopic placenta previa or threatened abortion. A 22-year-old pregnant woman is seen in the sonography department with heavy bleeding and cramps. She had a sonogram 1 week prior because of spotting episode of spotting, which reveals 6-week embryo. Current sonography reveals a uterus without evidence of embryo or the gestational sac. What is the more consistent? Which of the following? So, because it now it's no evidence of the embryo, and earlier a embryo was seen, and so this is a case of spontaneous abortion. So answer is spontaneous abortion. A 24-year-old G2P1A0 has a last menstrual period 9 weeks ago. She presented with the bleeding and passage of tissue per vagina. Bleeding is associated with the lower abdominal pain. The most likely diagnosis. So most likely diagnosis is incomplete abortion because it is associated with bleeding and passage of the tissue per vagina. Patient informed you that before her sonogram, she was previously diagnosed with the extrauterine pregnancy 10 days ago and was given the drug methotrexate. This indicates previously, she is most likely having which of the following. So there are two options because methotrexate is given for the ectopic pregnancy. So there are two options. It should be ectopic pregnancy, either rupture or unruptured. So the answer is because methotrexate is not given in the ruptured ectopic pregnancy. So answer should be the unruptured ectopic pregnancy. Patient inform you before her sonogram that she fainted several times just prior to being diagnosed with ectopic pregnancy. She had a salpingectomy. This indicates that she is likely which of the following. So, because salpingectomy is done because this is usually done in case of the ectopic pregnancy which has been ruptured. So this patient most likely has a ruptured ectopic pregnancy. Medical treatment is first option if the patient is hemodynamically stable and unruptured pregnancy. However, this patient stated that she has a syncopal attack followed by salpingectomy. So in which case rupture ectopic pregnancy is the most likely. So answer is rupture ectopic pregnancy. A patient present with the pain and spotting at 7-week gestation. Ultrasound confirmed that viable IUP consistent with the patient large menstrual period. Adnexal ring sign is imaged in the left adnexal region adjacent to the left ovary. Sonography finding describe which of the following diagnosis most accurately. So with here you can see a 7-week gestation present in the intrauterine location, as well as there is a adnexal ring sign is also present. So this is a case of heterotopic gestation. A pseudogestation sac does not have which of the following characteristic. So pseudogestation sac is a false sac which is present in case of the ectopic. So anechoic center, yolk sac failed to grow from the 1 week to next, and sac-like structure or sloughing deciduous. So which is having not seen in case of the pseudogestional sac. So yolk sac is the answer because it is not present in the pseudogestational sac. Next question is a rapid decline in the serial HCG level will most likely correlate with a so rapid decline, if rapid decline is there, then the chances are spontaneous abortion, which is associated with the rapid decline in the serial HCG level will be there. In ectopic, it's a subnormal elevation is there. In embryonic, there is a presence is there. Normal a slightly low level of the HCG level will be there. Heterotopic pregnancy, the beta HCG will be normal. But in spontaneous abortion, it will be there is rapid decline in the serial HCG. All of the following are the clinical feature of an ectopic pregnancy except so clinical feature of ectopic pregnancy, pain, vaginal bleeding, shoulder pain, and adnexal ring. So here the clinical feature, it's asking the question asking for the clinical feature. So pain, vaginal bleeding, and shoulder pain are the clinical feature. Adnexal ring is the ultrasound feature. So answer is D, adnexal ring. All of the following are contributing factor for an ectopic pregnancy except. So it's asking for the risk factor, which is not a risk factor for the ectopic pregnancy. So PID is a risk factor, associated reproductive therapy is a risk factor, intrauterine contraceptive device is a risk factor, advanced paternal age is not a risk factor for the, but advanced maternal age is risk factor for the ectopic pregnancy. So D is the answer. All of the following may be sonography finding often or in the presence of ectopic pregnancy except. So it's asking for the which is not a sonography feature of the ectopic pregnancy. So pseudogestional sacs, corpus luteal cyst, adnexal ring, and high beta HCG. So answer is D. High HCG, beta HCG is not a feature of the ectopic pregnancy. There will be slightly low level of the beta HCG there. Corpal still says pseudogestional sac and adnexal ring sign will be present in the ectopic pregnancy. All of the following would be associated with the lower than normal HCG level except. So which is having the more level of the high level of the SCG level. So molar pregnancy will usually have higher level of the SCG level, and ectopic pregnancy, blighted ovum, and spontaneous abortion will have lower than the normal SCG level. So answer is molar pregnancy. An intrauterine gestation may be differentiated from the pseudosac of the ectopic pregnancy. Why? So option are intradecidual sign, double decidual sign, peritropoblastic flow, all of the above. So all are associated with the all are associated with the intrauterine gestational sac, and they can be differentiated by these feature from the pseudo sac of the ectopic pregnancy. So answer is all. Classical clinical triad of the ectopic pregnancy is, so it's asking for the clinical triad of the ectopic pregnancy. So there is a pain, abdominal vaginal bleeding, and palpable adnexal mass. First, second is amenorrhea, pain and positive UPT, pain, uterine, intrauterine gestation sac and adnexal mass is the third. So in this answer is A, the pain, abdominal vaginal bleeding and palpable adnexal mass is the case triad, clinical triad of the ectopic pregnancy. Commonest shape of the ectopic sac is round or tubular or ellipsoid. So because ectopic is usually present in the tube, so it's having a tubular shape. Compared with the normal intrauterine pregnancy, the ectopic pregnancy will have high SCG, low SCG, or mild elevated SCG or high ARP. So ectopic pregnancy usually have low level of the SCG. Condition when the TBS ultrasound may miss an ectopic pregnancy. So when the ectopic pregnancy is located high out of the field of the view of the probe, when a pelvic mass is located between the vagina and adnexa, when a bowel gas is present between the vagina and adnexa, or all. So all the conditions are associated with when the TBS may miss an ectopic pregnancy. If it is located high up in the field of the out of the field of vision, or the pelvic mass is present between the vagina and adnexa, then you can not see the ectopic sac. Or when there is a bowel gas is present between the vagina and adnexa, then also you are unable to see the ectopic pregnancy. Decidual reaction is seen in intrauterine pregnancy, ectopic pregnancy, or both. So decidual reaction will be present irrespective of the location of the pregnancy. So it is present in both ectopic as well as intrauterine. Definitive diagnosis of ectopic pregnancy is done by transabdominal USG, color Doppler, transvaginal ultrasound, or laparoscopy. So laparoscopy can do the definitive diagnosis of the ectopic pregnancy. So answer is laparoscopy. Drug of choice for medical management of ectopic pregnancy is, so we already know the methotrexate is used for the medical management of the ectopic pregnancy. So answer is C. During the scan for the ectopic pregnancy, if fluid is seen in pelvis, why we look higher in the abdomen? So uh, option is provide the degree of the blood loss, is provide a greater sense of urgency to clinical setting, both or none. So answer is both, because if we look higher in the abdomen, we can see the more amount of the fluid present in the especially in the Morrison's pouch and other abdominal organs surrounding the other abdominal organ. So it provided degree of the blood loss, and it also how the urgency is needed in clinical setting. If the blood loss is less, then there is patient may be stable, otherwise it may become unstable soon. So answer is C. Ectopic pregnancy is more likely to grow for longer period in which part of the tube. So we already discussed that interstitial pregnancy is surrounded by the uterine muscles. So it can expand to a greater extent. So answer is B, because it may grow for longer period of time. Ectopic pregnancy are commonly located in which area? So we already discussed that fallopian tube is the most common site for the ectopic pregnancy to locate. So answer is C. Ectopic pregnancy defined as pregnancy in the fallopian tube, in the peritoneal space, outside of the uterus, in the uterine cavity, or outside of the endometrial cavity. So, pregnancy, ectopic pregnancy is defined as a pregnancy outside of the endometrial cavity, because if it is outside of the endometrial, it may be interstitial pregnancy, or cervical scar pregnancy is also ectopic pregnancy. So, if it is inside the endometrial cavity, then only it's a intrauterine pregnancy. Otherwise, it's a ectopic pregnancy. So this is all uh, for the about the ectopic pregnancy. Hope you find this lecture useful. And if you see again and again these lectures, you will able to solve the question in CBT and ultrasound examination, review examination very easily. So thank you all of you.